What's the best medication for sedation in the ICU? Is there a better way to diagnose COPD? Are U.S. adults more sedentary now than before the pandemic? We'll cover this and much more in this episode of the JAMA Editor's Summary. Hello, and welcome to our listeners around the world. Today is Friday, May 23rd, 2025. I'm Dr. Kirsten Bibbins-Domingo, Editor-in-Chief of JAMA and the JAMA Network. For this episode, I'm joined by JAMA Deputy Editor Dr. Preeti Malani and a special guest, JAMA Associate Editor and Intensivist Dr. Chris Seymour. Together, we'll be discussing JAMA's weekly content, including JAMA research published to coincide with the recent 2025 American Thoracic Society Conference. Hello, Preeti and Chris.
Hello. Thanks for having us.
Hi. So let's start by talking about the American Thoracic Society 2025 International Conference, which took place earlier this week in San Francisco. And JAMA published some great content related to that meeting. Chris, you handled two of the articles presented this week. Can you tell us about them?
Sure. Thanks, Preeti. So I really want to focus on the paper that was newly released in JAMA, and that's called Dexmedetomidine or Clonidine-Based sedation compared with Propofol in critically ill patients, the A to B randomized clinical trial. This is a really cool piece of work, and it's come to us from Dr. Walsh and colleagues, and is published in our Caring for the Critically Ill Patient section of JAMA. Now, one might say, we've learned a lot about how to sedate patients over the past 2 decades in the ICU. What is there still left to learn? Our typical practice would avoid oversedation. We're trying to keep our patients more awake, have spontaneous awakening that coincides with breathing trials and allows them to get off organ support as soon as possible. But a lot of the times, our patients are still requiring sedation for what's called ventilator-associated discomfort, and the right recipe still eludes us. The authors here have built on prior trials of the drug dexmedetomidine, which is an intravenous infusion and an alpha-2 receptor agonist. Dex, as we'll call it, was compared in this trial to Propofol, which is, in most ICUs, the standard approach to keeping our mechanically ventilated patients relaxed and synchronous with the breathing machine. Propofol is a GABA receptor potentiator. But what was interesting is the investigators also randomized patients to a drug called Clonidine, which is an oral alpha-2 agonist. And they sought to determine in a very large population in the United Kingdom of 1,400 patients, 41 intensive care units, whether any of these treatment strategies with Dex, Propofol, or Clonidine reduced the time to successful extubation. It turns out the authors found that there was no difference in time to successful extubation across these 3 arms. And it brings up a lot of questions. This data would suggest clinicians have a choice as to the optimal sedation strategy, but there's a lot left to learn.
Right. I think those points were made quite well also in the editorial by Dr. Sheehan and colleagues, which is titled The Search for the Single Best Sedative. And these authors suggest that it might be up to clinicians to choose which sedative is right for which patient, given the multiple competing interests here. And they also note that this trial, which is a very large trial, is among the first to investigate an oral agent compared with continuous sedation, another unique feature.
That's right. The editorialists make some great points that relate to the study design, the open label nature of the interventions, and that a patient's sedation requirements likely changes during the course of their time on mechanical ventilation. And what we might use at the beginning very well could be different from what would be optimal for the patient as they're weaning from the ventilator.
Very interesting. This was presented as a part of the JAMA Critical Care session, and I believe there's a second paper, but one that we've previously published in JAMA.
That's right. There was a second paper published in this session at American Thoracic Society. It was called Use of Life Support and Outcomes Among Patients Admitted to Intensive Care Units, and it was written by Drs. Emily Moen and Dr. Scott Halpern from the University of Pennsylvania. And that paper was looking to establish how organ support was used both before, during, and what might have changed after the pandemic.
Next, we also had a new article published to coincide with the ATS JAMA Pulmonary session that focused on chronic obstructive pulmonary disease, or COPD. And this article looks at a new multidimensional COPD diagnostic schema that includes respiratory symptoms and CT imaging, something not used in current diagnostic guidelines. The cohort study was conducted by the COPD Gene 2025 Diagnosis Working Group and Canadian cohort Obstructive Lung Disease investigators. Using this new COPD diagnostic schema, investigators could identify more individuals at risk for poor respiratory outcomes.
We also have a very nice editorial that accompanies this study from Dr. Polverino, who comments on the novelty of the study, especially as a milestone in redefining COPD diagnosis. She explains how including diagnostic criteria like imaging and symptom-based factors, rather than just airflow obstruction, can potentially better help identify patients with COPD.
The second article presented at the ATS Pulmonary session was also published earlier this year and focused on how a polygenic risk score can help identify patients with COPD.
Great. Well, thank you, Chris, for joining us to discuss the critical care papers presented at this year's American Thoracic Society meeting. Make sure to check out all of the JAMA Network papers, including 2 other articles from JAMA Network Open. We have a link to the entire collection in the show notes.
Thanks for having me. It was great discussing these papers and fantastic to collaborate with American Thoracic Society.
Let's discuss the research letters published this week. Dr. Lee and colleagues wrote about trends in sedentary behavior in U.S. adults between 2013 and 2023. They found a declining trend in sedentary behavior before the pandemic, which has stalled from 2021 to 2023.
In a second research letter, Dr. Ma and colleagues looked at management for internal and middle carotid artery occlusions. This is a longer-term follow-up of the CMOS randomized clinical trial originally published in JAMA in 2023. Symptomatic patients received extracranial-intracranial bypass surgery plus medical treatment or medical treatment alone. The authors conclude that the surgical group had more composite outcome events, including stroke or death, within 30 days, but there could be possible longer-term benefit in the surgical group.
We also have an editorial by Dr. Schmidt about prolonged caffeine therapy for premature infants. Dr. Schmidt talks about the MOCA trial recently published in JAMA, showing that extended caffeine therapy after discharge did not shorten hospital stay compared to placebo for preterm infants.
JAMA published a viewpoint by Dr. Ehrenkrantz and colleagues. They advocate for access to long-acting HIV treatment, especially in low- and middle-income countries. And Professor Watson gives an overview of in vitro fertilization and abortion. She writes that the fundamental argument supporting access to both of these services may not be as different as sometimes perceived.
The JAMA review this week is on immune thrombotic thrombocytopenic purpura, or ITTP. Dr. Pishko and colleagues summarize current research about diagnosis and treatment of this thrombotic microangiopathy. Here's Dr. Pishko in conversation with JAMA Associate Editor Dr. David Seimel on this week's JAMA Clinical Reviews podcast.
So TTP is a rare diagnosis where it's present in 3 to 6 per million. And so we always think about more common etiologies of a thrombotic microangiopathy. So things like disseminated intravascular coagulation, which can occur when there is severe sepsis present, or there can be patients who have had a transplant, a bone marrow transplant or a solid organ transplant, where some of their medications or graft-vs-Host disease may cause a thrombotic microangiopathy. So we kind of think about some of those more obvious or common etiologies for the presentation first. And then, if none of those are present, really what is going to define the diagnosis is the presence of severe ADAMTS13 deficiency. So it's really obtaining that laboratory value where we see the ADAMTS13 activity be severely deficient that is going to clinch the diagnosis of TTP.
Dr. Mahat and colleagues contributed a JAMA Insights article. It's about the potential clinical benefits of the newly approved drug, Remestemcel-L-rknd, for acute graft-versus-host disease in pediatric patients.
And the patient page this week shares important information about hantavirus, including transmission, treatment, and potential complications of this rare but severe infection.
Don't forget, you can search for JAMA Medical News or click the link in the show notes to find the latest articles in clinical medicine, biomedical research, public health, and health policy written and researched by our outstanding JAMA Medical News team.
Thank you for tuning in to hear what's new this week at JAMA. These highlights were brought to you by Dr. Preeti Malani, Dr. Chris Seymour, and me, Dr. Kirsten Bibbins-Domingo. This episode was produced by Daniel Morrow, Matthew O'Connor, Shelley Steffens, and Dr. Krista Roberts at the episode's show notes. To follow this and other JAMA Network podcasts, please visit us online at jamanetworkaudio.com. And thank you for listening.
This content is protected by copyright by the American Medical Association with all rights reserved, including those for text and data mining, AI training, and similar technologies.